and to be able to utilize AI to complete tasks in their professional lives, health, education, business, or otherwise, and to be able to grapple with new terms like prompt engineering to make sure that they're up on the cutting edge of what they've chosen to do as their professional pathway. And so we're really in a very unique moment and situation to learn in real time, faculty with students, that we need to simultaneously be adapting to. And that's a challenge, but as lifelong learners, we're up to the task. As many of you have heard, President Kerry has referenced generative AI in education and learning, as well as in professional spaces, as without a doubt going to change the impact of the way we teach, learn, and engage. And of course, teaching and learning is at the heart of what we do here every day and is what we do with our NYP colleagues. And Iona Education encourages students to engage with big questions rooted in the liberal arts. And through the engagement with big questions, students will demonstrate knowledge of the meaning and complexities of the human experience to be informed and responsible citizens, as we're about to have our vice presidential debate this evening, and to hopefully seek some peace and justice in the process. The context in which we do that and the questions we and our students must consider is changing. And this is not entirely new. The emergence of generative AI will qualitatively alter the way we and our students will ask questions and define knowledge. Fortunately, we have the tools to meet these challenges and events, like engaging our reputable experts to help us highlight the opportunities of things like generative AI in fields like healthcare. So we will continue as an institution to examine and consciously define the ethical parameters and principles about when and how to use generative AI. And as we are doing with Iona's new Gabelli Center for Teaching Learning and the upcoming Gabelli Speaker Series, we will engage with our colleagues to discern and address consequences that might emerge from this widespread adoption of generative AI in healthcare, business, government, education, and just about any field you can imagine. These might include a growing digital divide, commodification of technology and access to that technology, perhaps economic displacement and fear, but change is our new normal, and we need to pivot to ask not only what, but why. And that is our greatest contribution and strength. So while we embrace the new and the different, we must do so intentionally. And so with that, I'll turn it back over to Dean Dewada to introduce the panel for the evening and our wonderful guest speakers. Thank you so much.
So I didn't introduce myself. My name is, first of all, thank you, Provost Mulligan. I appreciate you giving the remarks. And my name is Kavita Dhanwada, and it is my great pleasure to have you all here this evening. Welcome to our Iona students. They are in great number, so I'm very excited. Our faculty and staff, our alumni, as well as our colleagues from our academic partner, New York Presbyterian Hospital, and of course, our wonderful friends from the community. So as I said, this is our inaugural lecture of our new speaker series, the Symposium on Health and Well-Being. And we are very excited about this initiative. And so I want to take just a few moments to explain why it's so important. Now, health and well-being are foundational and lie at the heart of everything that we do as educators and healthcare professionals. As our understanding of health rapidly evolves with advancements in medicine and technology, including artificial intelligence or AI, new challenges and important questions arise. How do we integrate these advancements like AI into holistic care? How do we prevent disease, promote mental and emotional well-being, and help manage stress in today's fast-paced world? This speaker series strives to provide a platform for thought leaders in healthcare to share their insights, research, and experiences. We will explore the ever-changing landscape of healthcare, focusing on innovation and societal needs. This evening, we will learn how AI is revolutionizing patient care, from diagnostics to treatment plans to enhancing the care team experience, and discuss how its growing role is shaping the future of healthcare. by bringing together experts such as physicians, researchers, policymakers, and practitioners. Our goal is to foster learning, engagement, and action to improve health outcomes in our communities. Now, we'll also look at integrative approaches to health and wellness, considering how social determinants of health, such as equity, access, education levels, mental health, nutrition, and exercise affect overall well-being. Now, these conversations will help us embrace a holistic view of health, leading us toward a healthcare model that is proactive, preventive, and responsive. This initiative supports our NYP Iona School of Health Sciences vision to be a leader in educating equity-minded healthcare professionals. Our aim is to empower future healthcare providers, not only in the care for patients, but to lead with innovation, empathy, collaboration, and a deep understanding of the diverse factors that influence health. We want to equip our students to not only harness AI and other technologies, but to work across disciplines in interprofessional teams to deliver meaningful improvements in health and wellness. Through this series, we aim to bridge the gap between classroom theory and real-world practice, sparking new ideas and strategies to enhance the lives of those we serve. With the incredible research that is expanding daily, AI will undoubtedly be a key component of this journey. We look forward to exploring its potential together. Now, in closing, I'd like to express my deep gratitude to the esteemed speakers who will join us on this journey. We look forward to the rich conversations ahead and hope that you all will continue to be a part of this exciting chapter as we in Iona's School of Health Sciences pursue our mission to positively impact health and well-being through the transforming power of education. So that's my talk. So as you see on your program, I'm supposed to step down. But unfortunately, Dr. Peter Flechette could not be here with us today to introduce our speaker. So I am thrilled. I have the honor to introduce our distinguished speaker today, Dr. Ashley N. Beasy. Dr. Beasy currently serves as the Medical Director of AI Operations at New York Presbyterian. She is a core member of its AI leadership team, collaborating with clinical, administrative, and research leaders to drive digital transformation and execute NYP's AI strategy. She leads NYP's largest AI initiative in partnership with Cornell Tech and Cornell University and oversees governance processes and infrastructure to ensure AI deployment across the system. She is a national thought leader in her work and contributes to multiple AI collaboratives. Dr. Beasy is also an assistant professor of medicine and cardiology at Weill Cornell Medicine, serving as an attending physician in consultative cardiology and cardiac intensive care. She leads informatics efforts within the Division of Cardiology. And her research focus is on digital health and informatics, including the use of AI models for the detection and management of cardiovascular disease and the safe and effective deployment of AI in healthcare. This work has led to numerous peer-reviewed publications and invited presentations. I just wanted to name a few of Dr. Beasy's publications to give you an idea of the work that she has been doing across a range of topics of how AI is influencing healthcare diagnoses. Way back in 2018, when we weren't saying AI every other phrase, she wrote a novel deep learning approach for automated diagnosis of acute ischemic infarction on computed tomography. And recently, implementing AI models in clinical workflows, a roadmap, and implications of bias in artificial intelligence, considerations for cardiovascular imaging. So in another publication, that focused on AI's potential to influence the industry and the new role frequently being seen in healthcare organizations, BC and her colleagues published The Chief Health AI Officer, an emerging role for an emerging technology. So she's like been doing all of this, as well as her other jobs. Dr. BC actually started her professional career as a computer engineer, receiving her BS in Computer Systems Engineering from Boston University. And she worked at IBM and Citi for over a decade, leading digital initiatives and operational risk management. And this was before earning her medical degree from Albert Einstein College of Medicine. She completed her residency and fellowship in cardiovascular medicine at NYP Weill Cornell, where she was the chief cardiology fellow. She is board certified in internal medicine, cardiovascular medicine, and clinical informatics. Wow, okay. Tonight, she speaks to us about AI in healthcare, shaping the future of medicine. So please welcome Dr. Ashley BC.
Thank you so much. That was such a kind introduction. And it's such a pleasure to be here in this beautiful campus and talk about something I am so excited about, and that is artificial intelligence. For those of you who all of a sudden think of the Terminator, you're safe, we're going to talk about AI in healthcare, and I promise there will be no robots involved, okay? When I think of artificial intelligence in healthcare, I think about a way to revolutionize the way we practice medicine. And I want to take you on a journey. I want to talk about how we are using AI, not in the future, but now. What are we doing in the hospital system to improve the way we diagnose disease, the way we treat patients, the way we improve the clinician and patient interaction, and the way we're reducing the burden on our care team members, the administrative work that they have. And then we're going to go in and we're going to talk about what are some of the areas that are evolving, some of the new areas that are just incredibly novel, that'll break down the silos of the petabytes of data that are in our electronic health record. So with that, I will start here, and we're going to talk about what is artificial intelligence, right? You hear this term a lot, but artificial intelligence in its broadest term is using a computer to make decisions and perform tasks that usually would require human intelligence. And when you hear about artificial intelligence, you hear a lot of terms. You hear machine learning, you hear deep learning, you hear neural networks. Machine learning is a term that uses data that's existing in the system to train a model. And deep learning is a type of machine learning where we use neural networks based on the human brain to predict patterns as a subset, again, of machine learning on existing data. And then lastly, a term you've probably heard more recently called generative AI, the foundational technology for software like ChatGPT, is where we use computers and we generate new data. And that's also based on machine learning and deep learning. So this is not new in the sense that AI is present in other industries. I know myself, I go to a hotel and I say, Alexa, what's the weather? And Alexa's not there. It's become part of my everyday life, right? I got here today from the city. There's no chance I would have made it here without Waze or Google Maps, right? We have become dependent. These are not just supportive tools, but we are partnering with them to complete regular tasks in our everyday life. And this is where I see the technology in medicine going. And so I'm going to break down AI in medicine into two broad concepts. One is, how do we use AI as a co-pilot? So how do we take data that's in our system, we use AI to analyze it, to generate data that can be assistive in our daily workflows. So really this augmentative approach to using the technology. And you see that this combined technology with the provider is how we're going to make clinical management decisions. The second approach, and I'm going to talk about the second, is how we are using AI in novel ways to gain insights into this data that me as a cardiologist, I can't see in the data, patterns, right? Right now we have radiologists looking at data. We have
the laboratory team, we have nurses, we have doctors in different clinical disciplines, all looking at data in silos. But how do we pull that together and create novel insights that otherwise wouldn't be recognized in the data? And so starting with this co-pilot approach, I'm going to take you on a patient journey. So we're going to start with a little girl. Her name's Julia. She's 3 years old. She's coming to the emergency department. She has about 5 days of fever. Her mother's very worried about her because she thought maybe she ate something. She's had this upset stomach, but it hasn't gone away. So what is the problem here? And what we're going to do is we're going to have our resident team come and see her. Comes and see her. She gets triaged. They take the vitals. This is our normal process in the emergency department. And what's happening in the background is this data is being processed by an AI algorithm that detects sepsis. Sepsis is a condition that's a systemic inflammatory process that can cause severe mortality related to usually a bacterial infection. The reason why this is important is it's the #1 cause of pediatric admissions in the hospital, 70,000 annually. About 8% are misdiagnosis, meaning the patient actually goes home and then has to come back because sepsis wasn't treated, which is incredibly dangerous. And so one of the first attempts at using AI in clinical care was the development of sepsis models and deterioration indexes. And what those models do, and I have a couple paper examples here, one which is from Johns Hopkins, where they developed a sepsis tool to diagnose patients early with sepsis. And what they found by pulling this information in parallel to the care team seeing the patients and creating an alert with a care pathway, they were able to reduce the time to antibiotics by just under 2 hours, right? And that's pretty significant when we're talking about an acute disease. Another paper published by Kaiser was for deterioration index. And what they did is they took a rapid response team made from nurses, and they gave them this predictive tool to actually pull the information from the chart and identify which patients were going to deteriorate so that they could go in and be proactive about chart reviewing those patients and contacting the primary team to make sure an intervention was done. And by doing that, they were able to show a marked reduction in mortality. And so these are tools that are being implemented. And one of the things you'll notice is that in all of these examples, the teams were thought about the change management and the care pathways to support the predictive nature of the results. And so going back to our patient, she gets the antibiotics because of this early sepsis detection. And the care team continues to figure out what are the next steps in her management. And they're saying, what is the source of this infection? Where is this infection coming from? And so they decide to use a new clinical decision support tool. And these are things that are currently in practice. And so I think this is a really good example of just ways we're actually improving outcomes in care today. And so the care team asks, what are the additional diagnoses that could cause fever and abdominal pain in a 3-year-old girl? Because just antibiotics often aren't enough. And I would say about 12 million cases a year lead to misdiagnosis. About 12 million cases of misdiagnosis a year. That's 5% of outpatient visits. And why is that important? Because with the right medical knowledge at the fingertips of providers, we can prevent those misdiagnoses. And here's an example of using current clinical decision support tools at the bedside to be able to put in conversational text to get a list of potential differential diagnoses. So now the team is saying, well, one of the things I didn't consider, common in pediatric patients is viral illnesses, but what about a liver abscess? That can cause abdominal pain and fever in our patient as well. And also in the clinical decision support tool, there's a recommendation for an ultrasound. So the patient goes ahead and she gets an ultrasound. In addition to the clinical decision support, I want to mention why is this different from our current technology. So current clinical decision support actually takes provider-generated summaries of existing literature and different diseases and references that. But one of the challenges is that there's 200 publications a minute. And so this is static, right? If you think about 200 publications a minute being generated in this novel evidence, Having static generated text in our clinical decision support tools, which aren't part of our mobile devices and are available on desktops, well, that's not really using real-time information. And I think that's the exciting part of where AI can actually pull in insights on a real-time basis from that current literature. And it's not just at large academic medical centers like ours. That is actually democratizing access to medical information across the world. So people have the same access to medical knowledge in their decision making as some of the larger academic medical centers. And so our ultrasound is ordered for our young patient, and it goes to our radiologist. Now, radiologist, I'm not trying to scare you away from medicine, I'm just talking to you about the realities of some of the workload that all of our care team face. They see 150 to 200 studies a day. That can be about 20,000 images. And so in this queue of studies, they want to know, well, what are the most critical? But if I can take the most critical studies and bring them to the top of the list, then I can get that patient care earlier. And so a lot of the AI solutions in the radiology space are targeted to just that, to prioritization of scans, to get the radiologist to actually review cases with pathology earlier. And this is a real example of one of the systems that we're looking at deploying now. So FDA, there's about 1,000 FDA products right now that are AI-based. Over 80% of them in the radiology space. It's one of the fastest growing areas. Part of it is due to the digitization of imaging data and the accessibility to actually run things like computer vision and deep learning models. But in the radiology workflow, what we're seeing is that we can use AI to not just prioritize scans, to take the better picture of the patient, to make sure there's less noise, and we're acquiring a quality image for our radiologist to read. We can also automatically read images for disease detection. So imagine I have this ultrasound, it detects the pathology, the radiologist reads it sooner, and that abscess is automatically measured by an AI tool, right? These are ways that this is being incorporated on a regular basis. But notice every example I've given you so far still has that human in the loop. That care team member, that radiologist is reviewing that final diagnosis and modifying the report based on these findings. Another thing is the troves of data. Our patient has come to the ED, they've been there for 2 days, they've had a collection of specialists and hospitalists see them and writing notes. Our radiologist wants to understand, well, what is a summary of their clinical course to correlate this image finding with their presentation? And this can be done with AI right now in our electronic health record. And this is something we're working on piloting as well. It not only helps this radiologist, it helps when the patients transition from the emergency department to the inpatient unit. They have a summary of this text and they can understand what's been happening in the patient's hospital course. So our patient, because this was rapidly diagnosed, they had their liver abscess detected, interventional radiology is called, and the patient gets an urgent needle aspiration of that infection. They continued on antibiotics and they get ready to go home. So we've been talking about our clinical diagnosis. We've been talking about some of the ways AI can help with our providers, but what about our patients? Our patients now being diagnosed, they've had a complicated hospital course. We have our nursing team, our pharmacists trying to explain what the discharge instructions are and what their medication and monitoring plan is when they go home. But wouldn't it be great if we could take that discharge summary and make it patient-friendly? To put it in terms that the patient and her mother, or maybe not the patient in this case, she's 3, but in some cases, and the mother can understand that they can bring it to their outpatient visit and they can actually interpret. And because one of the reasons why this is important is because we know that patients with poor health literacy, they have longer lengths of stay, they have higher readmission rates, and they have more errors on discharge because of a lack of understanding of the discharge instructions and medication management. And so we can reduce readmissions by about 30% by having patient-friendly discharge instructions. And that's what one of the teams at NYU did. They did a recent study where they took 50 discharge summaries and they run it through a large language model to make it patient-friendly that explains why you're here, what happened in your disease course, and what is your plan when you go home. And they found with decent observer variability that they were able to improve the readability and usability of these discharge instructions. And so our patient goes home, they're doing well, she goes back to school, she has an outpatient appointment with her provider. And so has anybody ever been to the doctor when they're sitting there and the doctor is like this? I can tell you've laughed. I've had that. I brought my kids to a pediatrician visit, and the provider didn't look up from the screen, and that's not their fault. Why is it not their fault? Because they spend 4 to 5 hours in the electronic health record documenting a day. 1 to 2 of those hours actually happens in the evening after work hours. There's a metric, it's called pajama time, to even measure it. And it's, for obvious reasons, called pajama time because it's after work. And so we're implementing something called an Ambient Scribe. And what that Ambient Scribe does is using your phone during your visit, a hospital-issued phone, with patient consent, we can transcribe a visit and create a note that goes into the chart for the clinician to be able to review so that during that encounter, they can actually have face-to-face interaction. And what we've seen is that this reduces cognitive load, this can improve time that's spent in the electronic health record. And what's really interesting about this is that during our initial pilot of this technology, even when it didn't save care team members' time in documentation, they actually, without knowing that time, reported they thought subjectively it saved them time. And so what we're seeing is that this is reducing the cognitive burden on our care team members, and we're excited to see how this can really improve our clinician-patient interaction in the future and bring back that love of medicine, and one of the reasons why we went into practice in the first place. Another example is augmented response technology. When you contact your clinician and your team member and you're responding back, there can be an auto-generated draft. And I think this just follows the same lines of a general theme of how can we take tasks like writing and make them editing tasks. And that's just a theme that you're gonna see, not just in medicine, but in your daily life. When you're generating letters or documentation, whether it's in clinical care and you're doing something like a prior auth, this is really gonna expedite the way that we do some of these administrative loads. And lastly, in this initial example is the research and clinical trials. So you can imagine if our patient were a candidate for something like a clinical trial that was researching advanced therapies in liver abscess, or how often you should do serial monitoring in a patient that's been treated for liver abscess, clinical trial recruitment is incredibly difficult. And there's a lot of inequities in the way that we recruit patients and the representation in clinical trials. And even in trial design and development of interventions, that process is much longer than it needs to be. With the use of generative AI technologies, we can improve the way we do patient recruitment for these studies, and we can expedite the way that we bring these interventions to the point of care. So I'm going to go into the second area I want to talk about, and that's something that's incredibly novel in the sense that we're trying to generate evidence to support that this is going to actually improve care. And that's using existing data in our electronic health record to develop novel insights in the diagnosis of our patients. So one of the large collaborations we have is between New York Presbyterian and Cornell Tech and Cornell University. And what we did is we brought together about 30 clinical faculty in the heart failure space, and we brought together about 10 to 15 technical faculty and students, and we said, let's build artificial intelligence models to improve care for our heart failure patients. Well, you can imagine in cross-collaboration in multidisciplinary areas, that can be challenging. People speak different languages, and we spent a lot of time figuring out where were the care gaps. So not starting with the technology, but what are the questions that we have in the way that we're caring for our patients, and then how can we apply this technology to really bridge those gaps and improve care? This is our team. Like I mentioned, it's quite large. And I want to walk through a couple examples of just what we are building and how we are applying it into this patient population. So one of the examples is using data. I mentioned data that exists already in the system. So you can imagine you come in and you get a CAT scan of the chest because you've been having this shortness of breath, you don't feel right, or maybe you've been smoking and you qualify for a lung cancer screen. And what we're doing is we're running our AI models on this data to identify disease processes that otherwise wouldn't be recognized. And we call this opportunistic screening. And a lot of the work and the design of the solutions is based on the concept of opportunistic screening. And here we're building a model to take a look at chest CTs and identify patients that have reduced left ventricular ejection fraction or reduced heart function. And the goal is to get these patients into care, to see a cardiologist, and to get downstream testing like an echocardiogram earlier before the disease progresses. Another example is identification of advanced heart failure. So the way we identify advanced heart failure now is through a test called cardiopulmonary exercise testing. That's only available in certain centers. It takes a certain subject matter expertise to be able to read these scans. And so what we want to do is we want to take data from an existing imaging tool like echocardiogram, which is more widely available. And we want to try to get insights and predict what we would otherwise need to get from a cardiopulmonary exercise test, which is our peak VO2. That's an estimate of exercise capacity. And so we built a data pipeline and a model to look directly at these images and predict the peak VO2. And why is that important? It's because the peak VO2 can help elucidate whether a patient is going from stage C heart failure to stage D heart failure, which would qualify them for heart transplant, for left ventricular assist devices, that oftentimes when they're diagnosed, they're not a candidate for because they're too sick. And so not only can we apply this to our patient population and get more referrals to our advanced heart failure team and get patients the care they need, but this could be applied in a broader population, nationally or internationally, at centers that don't offer that testing, to democratize the way that we're evaluating patients with this chronic disease. Another example is using ECGs to predict something like hemodynamics. Hemodynamics are done now through a cardiac catheterization. It's an invasive procedure where you put in a large, almost like an IV into the vessel, and you go into the heart and you measure the pressures. Well, I know that my patients, most of which who come through the emergency department, they get electrocardiograms. But me, I'm a cardiologist, I can read ECGs. I can't look at the ECG and predict whether somebody has abnormal hemodynamics or whether they have structural heart disease. And so these are the novel ways that we're applying and evaluating and studying the use of AI to improve care. Lastly, when we have our patients that come to see us, I just showed you a couple examples of diagnosis of heart failure and structural abnormalities in the heart. But when I'm seeing the patient in clinic, what do they want to know? Am I going to get better? Right? You would imagine you're a patient. I want to know, am I going to get better? And we don't have the answers to that now. And so if we can develop AI models that can look at these imaging studies and say, yes, you will have an 80% chance of recovery within the next year, then I can make a decision on whether I think that patient should have something called a defibrillator or other advanced therapies that would change the course of the trajectory of the way we manage them. And then this is the last example I'll give in the cardiology space, and that's using natural language process to look at these complex reports. Cardiologists, they use a lot of terminology that can be quite complicated, and on these procedure reports, it's not very patient-friendly, ultimately. I mean, if anybody has loved ones that they assist in their care, they understand the complexity of trying to interpret these. And so we can make patient-generated summaries, just like the discharge summary, but on procedure reports. And not only that, one of the things we're looking at is translating them. How many of our patients, they don't speak English? Imagine if we could provide these reports in another language. That's just an incredible way to improve the equity in the care that we provide. So I'm talking a lot about the exciting ways that we are looking at using this technology. But when I asked ChatGPT to create a picture of the medical director of artificial intelligence at New York Presbyterian giving a presentation to the New York Presbyterian Iona School of Health Sciences. This is the picture I got. I'm going to give you a second to look at it, right? There's clearly some things that are wrong. I mean, the text isn't right. I will say, I don't look like that, right? I mean, that's obvious. Maybe you look like that. That's also questionable, right? It's just to showcase that AI is not perfect yet. We have a lot to learn. And what are we doing to make sure that we're doing it safely? We've formed an AI working group, and that working group has a set of diverse expertise from legal, for information security, from health equity, our data science, our informaticians, to come together and really think about what are the ways that we need to do this responsibly. What are the questions we need to ask? And how do we create study designs that have risk assessment and mitigation in them to prevent errors taking place? This is also happening nationally. There's a lot of regulations, whether it's from the White House, the EU, the World Health Organization, NIST. A lot of these different frameworks are coming out and presenting themselves. And what we're trying to do as an organization is digest all of it and incorporate it in our own internal best practices to guide us in our decision making. A lot of this is related, again, to equity. How do we make sure that the decisions that are made are in the best interest of all of our patients, and not just the patients that may be represented more in our data? How do we make sure that we're not perpetuating biases or inequities that we know already exist in medicine? We do this as part of a lot of national organizations. There's the Health AI Partnership, the Coalition for Health AI. We work with other leading academic medical centers to just share ideas on what's working and what isn't, and how do we create the best practices all together in this arena. So what do people think about this? What do physicians think? Are they ready? Are we ready? Are you ready? Right? I mean, physicians, there was a poll by the American Medical Association, and it was about a third, a third, a third. So it's interesting. I think as we see artificial intelligence become more a part of our lives, and we recognize its value, and we do the change management and the implementation to bring it into our healthcare system in an appropriate way, I think we'll see these numbers change. If we can show the value and the safety, I think we'll see that people will find that by partnering with these tools, we're going to really transform medicine. And I think the broader question is, are we ready as a society? There's a lot of other considerations I haven't mentioned here today, and that's things like the digital divide, right? I mean, if we as an academic medical center can afford to study these tools and the technology and bring it to our patients, what about other less resourced healthcare delivery organizations? How are we making sure that people across the globe have access to these decision-making tools that we know and we're seeing improve care? How do we make sure that we're educating our next generation of students going into the health sciences, our next generation of medical students? This is a new paradigm which people are practicing. It's not only practicing medicine independently, but working in partnership with these tools. And this is going to be something that we need to study and focus on as well. We also need to think about how do we empower our patients? Right? Our patients are a big part of this, and we're starting focus groups to really understand what is the patient perspective on this. How much do they want to know? What level of transparency should we provide when we're using these tools in the decision-making in their care? And I'm really looking forward to seeing what that perspective looks like and how we can change the interventions based on this feedback. So I'm going to just leave you with this. I think this is an incredible time to go into the health sciences, to go into medicine. We're going to see this technology transform care. It's not only going to be something that providers are going to expect, like Alexa when you go to the hotel room. It's going to be something that our patients expect. Our patients are going to say, well, I know you think I have that, but what did the AI say? I guarantee it's really going to become ubiquitous in the way we work, and it's going to be revolutionary. So I'm excited to share this. I will leave the next introduction for our fireside chat and hopefully a Q&A.
So Lisa, you started as a staff nurse. We were talking about this a little bit earlier, and you've had quite an extensive career, not only in patient care, but in informatics. And now you lead an incredible group of nursing informaticists to develop tools that we're actively using. And I just couldn't help but take this opportunity to ask you a few questions of things you're working on, because I think it would be incredibly valuable for this audience to hear. And so I would love for you to share some of the current initiatives that nursing is involved with right now.
Thanks, Ashley, and thank you for Iona for having me here. So I am so excited to share with all of you some of the innovations that we're doing at NYP. I'll start with two. One is virtual nursing, so really taking care from the bedside virtually. And what we're doing with virtual nursing, and it's at 7 of our campuses right now, is we're having virtual nurses help to provide some of the tasks and work that is usually done by the bedside and offering that through the virtual nurse. And what they're doing is helping to do admissions. They're giving discharge instructions. They're doing some MRI screening, so really helping to go through with the patient some things that may be contraindicated for them if they were to go and get an MRI. And they're also doing a lot of education, so helping to support them at the bedside with education, whether it's on wound dressing, medications, etc. So really taking the opportunity to provide this work for them and to help assist our nurses at the bedside. That's one. And
Lisa, before you go into the next one, can you explain what is actually a virtual nurse? Can you
Sure,
describe?
absolutely. No, happy to. A virtual nurse is a nurse who is not directly on the unit. They're located in an area off the unit, and they interact with the patient through a camera. And so we, the frontline staff nurses, let us know that there's a patient who needs an admission assessment done, a discharge instruction done, a checklist to be completed, or some education. The virtual nurse will ping the patient on their television screen and say, "Are you ready for me?" And the patient connects with them, and they talk. They talk right through the TV, just like a Zoom. And they get all of their information between each other through that camera, and they're able to interact. And what's nice about the virtual nurse is that they're not distracted. They don't have call bells going off that they have to answer. They don't have people interrupting them. So this is really an opportunity for the virtual nurse to give that direct care to that patient at the bedside.
And what are some of the metrics that you're looking at? Like, do you expect this to help with, shorter length of stay? And one of the metrics we look at is, can we get a patient discharged before noon so that we can make sure that we can bring in all the other patients that are sitting in the emergency department and need to be seen?
Yeah, great question, Ashley. We're looking at, obviously, patient satisfaction scores. We want to make sure that we're meeting the needs of our patients when we introduce this kind of technology and this innovation. We're also looking at our RN satisfaction. So is this helping nurses at the bedside? Do they find that this is contributing to their care that they deliver on the bedside? And also looking at operational efficiencies. So are we able to provide those discharge instructions before 12 noon to help the flow on the unit and also to help those transitions of care?
And you said you had another example you wanted to share?
Yeah. So one of the things that we're piloting, hopefully by the end of the year, is telesitting. So really having that virtual model where we're having a one-to-one through the camera and having somebody being monitored through the camera on a continuous basis. So that will be something that we're piloting before the end of the year. But that's another technology, an innovation that we hope to have before the end of the year.
And so we may not all know what a one-to-one means. Can you explain what is the process that exists now?
Right.
And then how would this be an extension of that in Augmented?
Sure. So sometimes we have patients that need to just have somebody sit with them so that they don't fall, so that they don't get out of bed unattended. So we have people who actually sit with a patient throughout their entire shift just to make sure all of those things don't happen. And what we're now able to do is leverage technology so that we can have somebody do that same thing but through a camera and have the ability to do that for multiple patients.
I think that's incredibly exciting, and you could imagine
through the digitization of data, and we'll have more information on the topic here, like AI, where if you can imagine with telesitting, we could actually use that information on the camera to understand, is the patient getting out of bed?
Yeah,
Right?
exactly.
Because the bed alarms can be very reactive.
Correct.
But instead, with some of these alarms, by looking at that digitized data, we could say, oh, it looks like the patient's going to get out of bed. Let's support them. Let's help them. Let's see what they need before an adverse event happens.
Correct. Exactly right.
And I would love to hear from you. Is there anything that nursing is doing now in the artificial intelligence space?
Yeah, so right now in the artificial intelligence space, we are similar to the physicians. We are involved in NIH studies looking at AI technology and how that works at the bedside. We're part of a large NIH study right now at our Columbia campus, the CONCERN study, and it's very similar to what you talked about earlier, where we're trying to see, we put so much information into our electronic medical record. How can we use that information to leverage the care that we give at the bedside? So one of the aspects of the study we're looking at is taking all of the information that we collected. Are there information there that can give us an early detection that, hey, so this is a patient you might want to just keep an extra eye on because, you know, they maybe had recent changes in their vitals, they had recent falls. Like, so helping to flag that for the nurse to say, this is probably somebody you should kind of take a look at.
And I'm familiar with that study as well, and one of the things that I think is so incredible about it compared to the other deterioration index that we use is it's based on nursing generated data.
Yeah.
And we found that nurses are at the bedside sometimes the most. They're the closest to the patients.
Yep.
And that when they're documenting something, it's usually an important insight. They recognize that the patient's clinical status has changed. And sometimes this information is part of notes. It's not just part of a vital sign or a piece of structured text or an intervention that's done. It's really written in this text. And this model actually pulls some of the insights from those notes, which I think is incredible. And they've shown, it's almost 48 hours in advance, they can detect that somebody's going to have an episode that could bring them, could cause mortality or could cause a transfer into an ICU. And you can imagine in those 48 hours, a lot could be done to prevent that. So we're incredibly excited, I think, to roll that out to multiple campuses. We've talked a lot about the successes here, but there's not always, in what we do, there's failures too, or there's times where we try a technology and we're like, that didn't hit the mark. Are there any examples of that?
Yeah, absolutely. We piloted and started an end-of-day summary report. So at the end of the day, after the nurses are done with their shift, there is an end-of-day summary that is available. And what we found that from after we launched it was that we didn't really get great feedback from the staff, and we also found that it wasn't really helping them. And when we inquired as to why that was, the feedback was, the information you're giving me at that end-of-day summary wasn't really information that was helpful to me or helpful to the shift, the coming on shift, right? And I think what's important about technology and the innovation that we do is it's important that after we implement that is to take time after implementation to go back to the staff and say, did this work the way we intended it to? Give me your feedback. Nothing is set in stone. We can always go back and try to improve things, but it's important to get that information and feedback from the people who are using it, because that's the only way we're going to be able to make it better. So I think that was a learning point for us as well.
And I think that also brings up the good point that there's multiple stakeholders in this process,
Correct.
right? There's the team members who may want to try to reduce the length of stay. But that stakeholders that are making these decisions on where they see value of the technology may not be the stakeholders that are the end users of it. And so making sure you incorporate all of these team members, whether it's the doctor, the nurse, the social worker, whoever's going to be the recipient of using this tool in the development and testing process, because that's where you find out before you get too far along that this technology is not going to add the value that you thought it would. And given the time and effort it takes to evaluate this, it's good to know that up front, because ultimately what we want to do is provide value.
Exactly right.
So are there any areas of opportunity, you think, in using AI or other types of digital technologies in nursing? Like, where do you see this going?
Yeah, I think it's going to, we've started to talk about, and you mentioned it in your presentation, how it's transforming medicine. It's going to transform nursing as well. I mean, you hear across the country there is hospital at home, virtual ICUs. So this is all going to be the future that we move into, and it's transforming the way we deliver care at the bedside. I think the most important thing is on this journey that we are very transparent. We evaluate thoroughly the technology or the AI models that come out and make sure that as nurses, our primary role is to help explain this to the patients, right? So whatever technology, whatever AI models we bring in, we need to be able to be sure that we understand it, we trust it, that there are outcomes to show that it's improving quality and patient safety for our patients, because ultimately that's why we're bringing all of this technology and innovation to the bedside. How is it helping nursing? How is it helping our clinicians? And at the end of the day, is it working the way we intended it to work? And making sure we have that constant cycle of evaluation and feedback with our frontline staff.
And you could imagine as more data is generated and digitized across the patient journey, not just inpatient, but you mentioned hospital at home. So that's data generated in the patient's home, if they're continuing their medical care in their where they're living, and also in things like commercial wearables, right? That's becoming more and more popular, and we're using AI as a technology to be able to garner insights from that data and be able to present it in a way that's palatable to the care team that needs to evaluate it, so that we don't increase the burden with the digitization of this data. We want to be able to, bring it to the attention in a way that is going to change management in a positive way. I think
Absolutely.
you mentioned another couple of things. One was education, right? So that's one part of the change management process we haven't mentioned today. But we have to teach our care team. How do I explain this technology to
Exactly
my
right.
patient?
Yeah.
Well, I can't just say the AI told me to do it. I don't think that. Would you be okay with that? I don't think you'd be okay with that if your care team member said that, your clinician. So we need to provide the tools. We need to and we're being thoughtful about that when we integrate. We're doing a thorough job with education. We're providing things like model cards for each of these predictive tools that explains how is the model trained, how should it be applied, who's the patient population it's targeted, and are there any risks and considerations that need to be thought about when you're using it in
Absolutely.
care. And so we're doing quite a bit of that. And on the line of education, I think AI and also virtual reality and simulation is an area that we're going to see grow.
100%.
Yeah.
I agree with you. So how many of you saw that new technology from Apple, the eyewear? You saw that? Yeah, I know people saw that. They just launched it. I mean, can you think about how that could help with simulation, education, training, not just in healthcare, but think about it in education too, right? Like bringing that ability to get that kind of level of technology to help us with our work today. And so I think those are things that in the future, are really going to change the way education and training in the future and stuff,
So it won't have to be like when I was in medical school and I had to practice putting an IV on you. Instead, maybe we'll have the virtual reality, and in real time, we'll be able to see someone doing it and practice. And I think these are just a couple examples. We're just scratching the surface. There's a lot more to come. This is a great time to be thinking about medicine and technology and healthcare. So with that, I think we've left some time for question and answers.
Sure. I think that one of the big things is identifying who those key stakeholders are early on and bringing them to the table to understand what it is that we hope to accomplish with this model and how it impacts their workflow. I think the thing that we always have to remember is that technology is there to help us. And similar to Ashley's example earlier, like, she used Waze to get here, and it was helping her because it was giving her real-time directions while she was driving. She would not use a tool that that didn't align with that kind of workflow. And so when we bring technology and when we think about the right models, we have to make sure we understand their workflows. And that really starts with making sure that we understand who the stakeholders are, how is this going to impact their work, and how do we all align to make sure that this model and this technology works for all of us. Because if we don't have that buy-in, it's really not going to be successful, because it can't just work for one person or one team and not for the rest of us, because we work as one cohesive team when we deliver care for a patient. Yeah.
Oh. I'm going to, hello? Hello? There we go. Okay. Hello, everyone. Hi, Dr. Bisi and Ms. Linsangen. So I have a question. It was an amazing presentation, so I think it was super informative. I have a question regarding the future in like the resilient, the overuse of AI in healthcare, that people are going to be reliant on it. And when I use the word reliant, like there's an unhealthy reliance to it in the future, and how if we have to learn to maybe mitigate that providers are going to be overly reliant on not the helpful tools, but maybe overly using, I think you used a tool that was open evidence, was one of your slides. Is there a concern that there's going to be an over-reliance on tools like that in the future as new providers enter the field, or, you know, what have you?
There's something called automation bias, and you're touching on it by asking that question. I gave a couple examples there about using it as a diagnosis tool, or using generative AI as a way to generate text for review and editing as opposed to writing it, so draft generation. And I think if AI was correct 50% of the time, we wouldn't use it, right? And if it was correct 100% of the time, we probably wouldn't be here. It's going to be correct about 90% of the time. And what the challenge is that when something's correct 90% of the time, you're right, you're going to get used to seeing it correct. But when you get used to seeing something correct, like my Waze, I'm not questioning at this point, right? I am driving blind down the, Cross Island. We need to worry about the default, right? Mm-hmm. Am I going to stop editing it? Because 9 out of 10 times it's right, I'm going to stop editing that generated draft message, or that note that was generated, or remeasuring that liver abscess that was automatically segmented based on my AI tool. And that's something that when we're rolling it out and we're creating these responsible governance groups for responsible AI, we're looking at automation bias. So I can tell you, well, did it save time for the provider when they created that draft message? But I can also tell you if they submitted it too quickly, right? And so we're looking at that. We're looking at that reliance on the technology, and are the risk assessment and mitigations in our workflow that cause someone to stop and double check, that maintains that human in the loop so that the human is making the actual care decision and intervention, is holding true. Because we do feel strongly at this point in time that we're not in a fully automated capacity. We really are relying on whoever the care team is to take that information and make the ultimate decision. But you do bring up an important point, and it's something that we have to be thoughtful.
I'll just add to Stephanie, I think as educators and teachers and as clinicians, both nurses and providers, it's our responsibility to also teach the next generation that's being brought up in this, that technology is there to help us, but it doesn't replace us assessing our patients and going to put our hands and seeing the patients ourselves, right? Because but that's something we have to teach, and we have to incorporate that in our education and training. There's a lot of work, as Ashley said, about looking at that bias, but we also have to remind, when we're teaching the next generation of staff that's coming on, that that's technology, but you're still the clinician and you're the person that's interacting with the patients, and we got to make sure that we take a look at that patient, no matter what they're telling us, Yeah.
Hi. Just to kind of expand on that question a little bit more, one of the biggest challenges right now with AI are hallucinations, like fake information coming up. It's not really an issue when you're researching which iPhone to buy, but in healthcare, I'm sure it's like a pretty big deal. So what kind of safeguards are being put in place for stuff like that, especially if you're not even sure if something is like accurate, if being recommended diagnosis or something like that?
Yeah, there's a couple different ways you can do it from a technical perspective. I'll just give one example that's called retrieval augmented generation, or RAG. And what that is it takes something like GPT and it uses that almost like the brain, but then there's a database of information. One example that we're using this technology is to ask questions on our internal policies and manuals. So I put all of our internal policies and manuals in one database, and then I use GPT-4 to ask questions on just that information. So I'm using the technology of GPT-4, the conversational abilities, but I'm pulling only from information that I've given it. So that's one of the examples of a safeguard. Another one is in these clinical decision support tools. We aren't using this open evidence, we're using a different one right now, but they provide references to all of the differential diagnoses and clinical recommendations. There is a link to the actual guideline or paper, and so that you can go in and you can see where that information has been pulled from. But you're absolutely right, hallucinations is a real thing. In other instances, we're also making sure we provide feedback mechanism for whoever's using the tool, so like the thumbs up and thumbs down, and so we can get that information in real time and make adjustments, as well as adverse event reporting like we would do for any quality management system. So there are mechanisms, and it's certainly something we're trying to be thoughtful about.
Hi, thank you so much for the really helpful information that you shared. I was just wondering if you could speak a little bit more about how you see us leveraging AI to enhance cultural competency and cultural humility in healthcare provision. I know you talked a little bit about simulation, but if there are other ways.
So, that's a really important point. I think when we talk about equity and the use of AI in cultural simulation, I think there's some early wins. I think some of the early wins may be in translation of documents, right? Being able to reach out to our patients that aren't English speaking and provide them information that they may otherwise not have access to because of these language barriers. And that's something that we should be doing, right? I think there's more community outreach that we can do with this technology. An example of that is we have mobile lung cancer screening tools where we have the CAT scans in the mobile units, and we're outreach to communities that may not be aware of lung cancer screening protocols. And we are about to pilot a AI-based technology that can identify coronary artery disease on these lung CTs. So now, not only am I going out into the communities where patients may not be brought into care until their disease manifests in symptoms, but I'm gonna look for lung cancer, and I'm also gonna look for coronary artery disease. What's important is that with these communities too, we built out the appropriate care pathways to not just detect the disease, but to make sure the patients actually get the follow-up care, and we close the loop, because that's how we're gonna see the change in management that we want. I think those are two big examples.
I'll just add that there's also innovation in this field where when we talk about ambient technology, there's a company that's really training their technology to pick up accents, especially thick accents, so that when we try to use that ambient technology, it can pick up if people have a thick accent when they're speaking with us. So I think that's also a way that we're bridging some of that cultural stuff, that we're having that ability to still get clear information, even with patients who don't have English as their primary language. Picking that up.
And it's important when we think about bias in these tools to make sure that the data we're training the models on represent the patients who are applying the models. And that's one of the reasons why we're doing a lot of internal development. We have a 10 hospital system, and we have a very diverse patient population. And so we know when we're building our tools that when we're deploying them, it's going to be representative. And that's not true for all commercial products. And so we're very careful. That's one of the questions that we ask is, who should this be applied to? And does it represent our patients? Because that's That's who we're trying to deploy. I think it is, but the development and deployment process is not an easy one, and it's very select hospital centers that are really, going into this space. And it's important because it allows healthcare delivery organizations to be a lab, right? The care team members know the right questions to ask, which starts with the questions, not with the technology. Identify the care gaps and then build these, but not only build them, but deploy them so they can understand the efficacy. But you're right, across all the healthcare systems, nationally, internationally, more of the data is being digitized. And so we may see, as costs such as compute and costs for creating the appropriate data infrastructure go down, that maybe it'll become more democratized.
Hi, my name is Karen. I'm one of the nursing faculty teaching in our new master's program. The current cohort now has 9 students. They're all working in one of the NYP practice environments, so thank you for promoting the program. I just wanted to talk about ways of knowing as a nurse. So, we learn that there are multiple ways of knowing about things, and one is through empirics. But I wonder what the role of clinical intuition is in the advent of AI, because if anybody's ever been a practicing nurse, I was an ICU nurse for many years, you developed some sort of sixth sense about things that were potentially cooking with the patient, but it wasn't manifested. I see some heads nodding like, you know what I'm talking about? You just have this feeling that something's brewing, but yet the patient's hooked up to every monitor, every device, everything looks fine, and then in an hour, things happen. So I just wanted to, for both of you, nursing and physicians and others, where does clinical intuition sit?
Yeah, I think that's a great question, especially in the age of technology and as we develop more reliance on technology. If you look at our EMR system, we have something called the brain, and that really reminds nurses all the time, you gotta do these tasks, I'm gonna answer that in a couple ways. One, I think that's why I mentioned before, us as leaders, us as preceptors, us as the people that are teaching the next generation, we have to remind the nurses that to trust their guts. And I know that's not always easy the first year out of nursing school, but that comes with experience and time. And that is something we should encourage, right? Don't ever just take something for face value. So I was an ER nurse, and there would be a patient who'd be like, their blood pressure was like 90 over 60, and people would be like, oh my God, we gotta go do something. And I was like, well, why don't we go look at the patient first? You know what I mean? Because some people, that's where their baseline is. That's how they are. And they were talking and stuff like that. And I think we have to emulate that behavior. And I think that that's something, clinical intuition is something we can emulate and we can support especially new nurses at the bedside. I think that that's something, and I think that, again, we have to remind them that this technology is a tool, but it doesn't replace them. It doesn't replace them assessing their patients, seeing their patients, going out, and if you're concerned, say something,
I love that question because for me, it's at the top. I work in the cardiac intensive care unit, and my nurses are everything, right? I would take their opinion. There's things that will never be digitized and represented in the data, the smell, the feel, the touch. And I think one of the things is that the technology will hopefully create a system where the care team members, the clinicians, the nurses, the providers can spend more time with the patient, building that intuition and garnering insights that provide, things that wouldn't be generated from data, because AI is working in the background to remove some of those other tasks, whether it's an ambient scribe for nursing that can help document flow sheet data, thing automatically, or Bluetooth, blood pressure cuffs where the data automatically gets entered into the electronic health record, so that people aren't doing that administrative work and instead are gaining that insight and that information that's number one most valuable.
And technology is not going to pick up if a patient is feeling sad, if a patient is less engaged. That's you. That's the clinician, right? And that's what we bring to the table. And that's part of the whole care that we give to that patient. And no technology is going to tell you, oh, your patient's suddenly sad today. You're going to pick that up, especially when you're managing that patient or taking care of that patient for 3 days in a row. And you're like, he didn't eat his breakfast again, and he didn't eat his lunch, but yesterday he ate it. Something's up. You know what I mean? Like, technology's not going to pick that up for you. And we just have to remember to we have to emulate that behavior, and we have to teach that behavior, and we have to encourage that behavior. You know? So.
Thank you very much for what you shared today. It's very valuable. So my question is somewhat related to some of the previous person's question. So I'm a faculty from the Marriage and Family Therapy department, and our work as a psychotherapist is really focusing on language, right? So the language, when you talk earlier, like using AI in healthcare, which involves a lot of using language to, for example, to reduce the doctors or nurses' workload by helping them documentation or a lot of other tasks related to the language using the natural language processing and information retrieval. Then to me, I feel like the language is very, very important. If we are like using AI to do documentation, and some of the words that we use will gradually kind of like be different than the words that we are using on our own. And then also thinking about like how do we promote critical thinking for training students, and also helping with using AI to promote critical thinking. Because on the one hand, you want to lower people's workload by using those AI tools. On the other hand, when they don't do those documentation, maybe something is missing, and then this critical thinking, not only about the time they spend with the patient in real time, but also in the process of documentation or other things like administrative tasks that are taken away from by AI, if my question makes sense.
You know, I had this debate with somebody the other day, and we debated, well, what will happen? Okay, the argument that I had, and this is with the head of American Medical Association's provider well-being. She's the vice president of provider well-being, and she said something similar. She said, well, when I write my notes, that's my time where I'm creating the plan and I'm thinking about the patient. And I said, well, that's not how I work. You made index cards when you were studying for tests when you were growing up, didn't you? And we had this whole thought on how people learn, and how people learn and how people develop critical thinking all the way back to how you studied for tests in grammar school. And I think the bottom line is we don't know. We just don't know. This is so new. Because for somebody like me, I didn't think that it would affect my critical thinking. I don't do that through writing. I'm like, just get this writing done so I can actually think about the patient. And she had a very opposite view. So I think it's something that we need to study, we need to track, we need to figure out. Does it change? Or is it a new way of doing something that, like to Lisa's point, we can educate people on, that maybe there's a different part in the process where that critical thinking takes place that's not tied to the documentation. Does that answer your question?
Yeah, thank you.
So I'm asking you the final one.
No pressure.
Yeah, so I'm Deblina. I would like to introduce myself as the 40% of the clinician who is equally excited and equally concerned. My question is twofold. First and foremost is that how about our clients and our patients' privacy? How much it is secured? And second is that I'm a marriage and family therapy student. There are documents of our patients which are confidential, but if we have put the documentation done by AI, how about our ethical practices coming in between, how we can save ourselves? So this is my question.
Can you say, what was the documentation again? It was
The documentation is that our clients, all information is confidential and we cannot release it, but if we have processed it through AI, what if the ethical practices come in between that I have already released the documentation through AI? So the consumer privacy or my patient's privacy is one side and the ethical practices in the second side. So this to how we can coordinate with AI, but I love AI.
I see where you're talking about the 40% here. So, great question, right? And so, one of the things that we do well at our organization is information security and data privacy, and AI is no different. With any organization we work with, commercial products, vendors, we have strong business associates agreements where we look at that data privacy and we ensure that there's patient consent and use of that data in any tools. And we're very conservative in the sense that we don't let commercial entities use that data to rebuild what they're doing. It's really only we use that tool, it's fixed, and we're using it on our patients, and that patient data is not reused for secondary purposes. That's something that we've made sure of as we're working with these clients. So I think that's one aspect of it. And the same as when we're building it, it goes through any other research process, right? We have our IRB that improves, the human rights and protection and use of that data in the building of the tool, and whether you need to get patient consent or waiver of consent depending on the circumstances. And so that's incorporated in all the design and development of our tools. And our patients are part of this. So I gave an example of the Ambient Scribe. But we not only do one consent, a patient's consented for it at the time they're at the front desk, and in a written consent, but they're also consented by the clinician in the visit with an oral consent to follow. And so we're trying to make sure that we create as much transparency as possible to our patients so that they have the ability to understand where AI is being used and have control over that data where possible. So it's something we take very seriously, but a great question because of big concern with the building and development of this technology.